So, oops. Let's see. Jennifer, why don't you take this case?
So there is transverse lucency within the fabella. It's suspicious for a fracture of the fabella.
Okay, so that's a fabellar fracture. And here you can see the larger component on the MR scan and the smaller component on the MR scan here. And then on the axial images, you can see the two fragments. This would be very difficult to see. It's pretty easy on the plain films, but on the MR scan, I think it'd be easy to overlook this. Okay. Actually, what do you think?
Well, it's a dislocated knee posteriorly, and it's very strange that they were able to get an MR scan for this patient while he was dislocated. But you'd be worried about vascular injury to the popliteus artery, and yeah.
This is from Colorado. So you see.
Popliteal
And I'm going to show you the images of this. You can certainly see that the ligaments are torn.
Yep.
In this place. I want to look up some vascular injuries. Okay. Let's see. Michael, what do you think of this?
Some coronal images of the knee. Just looking that there's some fluid signal kind of adjacent to the medial femoral condyle, and also I know those are along the the tibial plateau, and there's like a a hypointense lucency through it. But this says trauma 15. Now I'm seeing it says trauma 15 days ago. Fracture medial condyle.
History. Okay, so here we can see that there is a little fracture here on the
condyle is misspelled.
Well, I didn't spell that. That comes from Ciro Duarte. That's the way they spell it in Brazil. Yeah, right. So we can see that there's a little fracture here. This is actually the opposite side of what kind of a fracture do you have if it's on the lateral side over here with an ACL tear?
It's the gun fracture.
So the gun fracture is over here. There's a thing called a reverse. What? The anterior lateral ligament comes down and attaches there. There's a reverse Sagan lesion, which happens on the opposite side, which you can occasionally see in posterior cruciate ligament tears, but it's pretty rare. So this is on October 9, 2014, but if you see this, you'd want to look for the PCL. This is 3 months later.
There's, the bone marrow's kind of markedly heterogeneous, a lot of low area signal. And 3 months later, is this kind of like an appearance of like a disused osteopenia?
Okay, so this is actually what the marrow space can look like with disuse. And then when they started walking again, this a few months later, you can see that this all resolves and goes back to more normal. So that's just an indication of disuse, osteoporosis, or due to immobility. So that's okay.
John?
Yes.
On the initial images, I don't see any trauma to the lateral side of much
maybe a little trabecular bone injury.
Substance.
Edema.
Yeah, I would expect quite a bit more, wouldn't you?
Why would you expect more?
To get a avulsion fracture
Over here?
right there, it takes quite a bit of trauma.
Yeah.
I would expect more injury to the lateral side from the impact.
I think it just depends upon the mechanism. If this were
I suppose, but it just strikes me like it should be more
okay,
because that's where the impact is. The avulsion is on the medial side, but the impact is on the lateral, so that's where the real trauma is.
okay.
Well, we're not going, which makes me think this might be a little delayed.
Well, 15 days.
Oh, 15 days. I see. I didn't read that. Pardon me. Forget everything I said.
No, that's good. So it might have been more edema if it had been scanned earlier. That's a good point, John. And then that's just the marrow changes that you can see with disuse. Okay.
So 24-year-old left knee pain and weakness. There are 2 axial images through the knee joint and tibia. Pain and weakness. There's a joint effusion, increased signal intensity kind of along the posterolateral subcutaneous tissue. It's kind of loculated. It could be a ganglion cyst. That fluid extending along the posterior soft tissues. And then just posterior to that. Yes.
So we got these 2 areas here. This is at a different location. What do you think these might be? I mean, they could be cysts, but they look like they have a lot of septum in them. Let me give you another. So you really want to see what these look like going up and down. Here is a sagittal image through one of them, and here's a coronal image through another.
So it looks like striations in the muscle, perhaps muscle strain.
This isn't really the course of a muscle. The muscles usually come in and either attach. The proximal muscles attach distally here to the tibia. The distal muscles originate here from the femur. This looks like it goes right past the joint space. Same thing here. Here is another images, and it's what you can see. These are actually nerves, but they're big nerves, which you can see coming down here. These are where they're becoming a little bit more normal size, a little bit lower down. So what do you think of? We'll see a lot more of this later. What do you think of when you see big nerves?
So either some type of neurofibromatosis.
Hey, is there anything of neurofibromatosis? And you should see they should be more focal areas of nerve enlargement. This looks like it's really enlarged over a long distance, and it's relatively uniform in size until they start branching distally. And this is Charcot-Marie-Tooth syndrome. Charcot-Marie-Tooth syndrome actually is a cluster of a number of genetic abnormalities. It's not really a single genetic mutation. So it can present in varied ways depending upon the individual and which abnormal alleles the patient has. When we talk about the spine, we'll talk a little bit more about that. But when you see large nerves, there is a differential, but generally if they look like they're big fat nerves of the peripheral nerves, then you need to think of Charcot-Marie-Tooth syndrome. And here it says more than 80 different genes. I'm sure by now there are more than that. But it's not uncommon. I mean, it's uncommon, but it's not really rare. It's 1 in 2,500 people. So during the course of the year, you really should see 1 or 2. Okay, John, I'm going to cut out here so that I can reconstruct this tape. And so I'm going to cut out and then log back in again, and I'll see you in a minute. We'll start the next lecture.